welcome to today's webinar on creating safety during home visits, an introduction to trauma and violence-informed care. My name is Sarah Carsley, and I'm an applied public health science specialist here at PHO, and I have the pleasure of co-moderating today's session. Before we begin with today's presentation, I would like to acknowledge that I'm here in Toronto, on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties, signed with multiple Mississaugas and Chippewa bands. I'll now mention a few housekeeping items. To enhance the presentation experience, participant audio and video has been disabled. The chat pod has also been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session, and a discussion and question period will follow this presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today, Dr. Susan Jack. Dr. Jack is the lead for the Public Health Nursing Practice Research and Education Program, or PHN Prep, and she is committed to integrating the principles of trauma and violence-informed care into professional practice and curricula as a strategy to improve client engagement and health outcomes. Over to you, Susan.
Great. Thank you so much, Sarah. Once again, every month, it's such a pleasure to connect with everyone and to be here to think about ways to enhance everyone's practice and work with individuals and families and children in your different communities. And today's webinar is going to be an introduction to the concept of trauma and violence-informed care, with a really key focus on why adding the V to trauma-informed practice is really transformational in how public health nurses and other practitioners view and interact with clients and families. And it is genuinely my pleasure to introduce my colleague, Dr. Nadine Wathen, who is a professor at the Arthur Labatt Family School of Nursing at Western University, as well as a Canada Research Chair in Mobilizing Knowledge on Gender-Based Violence. And Nadine will be familiar to many of you. Nadine has done extensive work in public health, on projects and initiatives through the Public Health Agency of Canada. And at a more local level, I know that she and I have done many different workshops at different health units around the province on this concept of trauma and violence-informed care. So Nadine's research examines the health and social service sector response to gender-based violence, interventions to reduce health inequities, and the science of knowledge mobilization. And a really specific focus of Nadine's work is really around developing and evaluating person-centered interventions that enhance health equity and take a gendered and trauma and violence-informed approach to providing services to individuals, particularly individuals who experience different forms of interpersonal violence, structural violence, or marginalization. So again, it's my pleasure. Welcome, Nadine. This is going to be the first of our series on trauma and violence-informed care in public health. And Nadine, thank you for creating a foundation and an introduction to these concepts for us.
Thank you so much, Susan, and good morning, everyone. It's truly a pleasure to accept this invitation from my good friend and colleague, Susan, and to speak with you this morning about a topic that is near and dear to my heart. I will start by acknowledging that I'm sitting on the traditional lands of the Anishinaabe, the Lenapehoek, the Haudenosaunee, and Chinookan nations in what is now known as London, Ontario, and I pay my respects to elders past and present for the privilege of working and living on this land. So as Susan said, this is the first of a series, and I've been asked to give an overview of what we call trauma and violence-informed care. As mentioned, in the materials introducing this session, really what we want to be able to do by the end is define and explain the importance of that V. So I know that many, if not most of you, have been familiar with the concept of trauma-informed practice, and might be wondering what the V is all about. So really, this session is, what is the V all about? I will stop for a moment. Susan mentioned that I come from the area of gender-based violence, and in particular violence against women and domestic violence. So why am I doing research in this area if my primary area is gender-based violence? Well, I found over the decades that I've done this research that sadly, as I work with women's shelters, for example, they are not getting less busy. And I do feel that taking a more structural approach and starting to look at this big V that we're going to talk about today is really important in being able to actually shift some of those downstream effects, and your public health folks, so you certainly understand the importance of upstream thinking to avoid downstream harms. And this is really what things are about today. So I'll give an overview of what we call the 4 principles of TVIC. This is the first of a series. I know Susan will be presenting more detailed strategies and tactics that you can use in your practice that will articulate those principles in the next of the series. So this will be an overview. Importantly, and I've started to sort of talk about structures and structural issues already, organizations have a key role to play here. Sue mentioned that we've done many workshops with public health units, but also with other organizations across the spectrum of health and social services. And we need leaders to be aware of this. We need organizations to shift things such that providers can change their practice. So you will hear me reflect on that. Some might say harp on that as we go through the presentation. And then I'd like to also start pointing you to additional resources, because we have spent the last 5 or so years really trying to mobilize this knowledge such that it's freely available for you in your practice. So I wanted to start with a bit of a scenario, and you can do this as a reflective exercise. We're going to come back to this a little bit later. In an interactive session, we'd be able to do a bit of Q&A and get your thoughts, but just jot a few things down. So you just started working with a young mom and her family. She has her husband, her 3 children, the ages specified here, her husband's parents. They all live together in a home. They've just arrived from the Middle East quite recently, less than 6 months ago. So you arrive at the first visit with a professional interpreter, and the husband refuses to let you in, saying that his English is good and they did not request interpretation. And they had actually declined that when they were asked when setting up the appointment. You leave, you're frustrated because now your schedule has been upturned a bit. You call later and you leave a message because nobody answers. You say the time you will visit next, but you don't hear back. You then arrive at that next visit, but nobody answers the door. Just jot down your feelings in this moment. If you've had a situation like this, what did you think then? What did you do? And we'll come back to this later, as I said, after we've moved through some of the content. So I've learned from Susan and the wonderful nurses with whom I've worked for many, many years that the core of home visiting and the core of much of nursing is the nurse-client relationship. And that therapeutic relationship is foundational to be able to do your work, to be able to assess and identify the needs of the family and the client, to collaborate them, to develop that care plan, and to work with them to actually implement the different interventions, see how they're working, iterate the plan, and then hopefully promote behavior change and improved health and well-being. These relationships are founded on trust, respect, and mutuality. And we argue that these are all core aspects of trauma and violence-informed care, and that with a more focused lens through TVIC strategies and principles, this will help develop that therapeutic nurse-client relationship. But we also want to acknowledge that this work is not easy. And in fact, this is the slide where I say, you're not alone in some of the things that you might be feeling. Certainly, we know the last few years have challenged the profession, have challenged all of the caring professions, and caused certainly additional emotional labor and what we might also call moral distress. And what we mean by this is we come into nursing or other caring professions to do good, to help people, to support families, to ensure that babies have the best possible start. And we also have professional ethics that guide our work through our colleges and so on. These values and ethics are not always implementable in practice, and that's often because of the structures in which we're working. So if an organization is not set up such that you're allowed to be flexible in your time use, you might not be able to deliver the care that you feel you should be delivering based on your professional ethics and the values that brought you into the profession. And that can be expressed, those mismatches can be expressed and felt as moral distress, that there is actually a negative emotional response to doing work that you know is not ideal for those you serve and for your own well-being. And again, this can happen when these policies and practices or an organization's culture are not matching with those ethics, values, and norms. And it happens among people, among teams, in organizations, and in broader society. And as I mentioned, the last 3 years have made this worse. I would also argue that things like policy or legislative decisions to cap pay for nurses and other health and social service professionals in the context of rising cost of living is another form of structural violence that actually can cause moral distress. And we do see professionals leaving workplaces in droves these days. So you're not alone. These are important macro issues that frame the ability to do the work. So I just want to give a little bit of an overview of being trauma informed before we start adding the V. So what is trauma? Most of you are nurses in practice. You know what trauma is. So I just go through a few of these slides to make some important points that help bring us to the V and the importance of the V. So trauma obviously is the experience of, and importantly, the response to negative event or events that are at the threshold of threatening your feelings of safety, life, and integrity. So they're overwhelming in terms of your ability to cope. So it's beyond everyday stress. And in fact, post-traumatic stress, we would say, is an anticipated response to these significant threats. And we'll sort of go over the physiology and the broader structures that influence this. Traumatic stress can be acute, so single events, or chronic and complex from repeated experiences. And this is where the work that Susan and I have done in the area of violence, for example, comes in, repeated exposures to threatening events. And the responses can look very different among different people. So things like shock, terror, shame, powerlessness, again, these are anticipated responses. Not everyone will have them, and not everyone will have the same one, but they are anticipatable, if you will. You should expect when people have experienced these sorts of traumas that there will be this sort of response. And these are often framed as fight, flight, freeze, and fawn. So you might see people get aggressive and want to fight back, or they might leave or freeze, disassociate, and so on. Or they might try to get you on side by exhibiting fawning behaviors, agreeing, overly agreeing, that sort of thing. And all of these can happen in your practice, and you might actually think of occasions where you've seen these. So the point being that what this looks like is not only based on an individual's personal experiences and what's worked for them in the past, but a range of factors, including the sorts of protective factors around them that could help buffer the effects of stress and post-traumatic stress on their lives. And we also know that trauma is distressingly common. So this is data, and again, you're not supposed to be able to completely read this map, and I won't stay on it for very long, but the World Mental Health Survey went to 26 countries and looked at what the proportion of the population that had experienced significant traumas that would meet the threshold of post-traumatic stress responses. And the red zone countries are the ones where it's over 70% of the population. Canada was not actually included in the World Mental Health Survey, but similar work shows that 3/4 or 76% of Canadian adults would also meet this threshold. So we would definitely be in the red zone, along with the US and some of the other countries that we see here. So trauma is everywhere. If we have not ourselves experienced it, then certainly we know many people around us, including close to us, who have experienced it. And this is an important point because we are going to argue for TVIC as a universal approach, recognizing the prevalence of trauma. These are some examples of traumatic experiences. As I mentioned before, they can be situational or interpersonal. They can happen once. They can continue to happen in a chronic pattern. I've highlighted on the left the sorts of traumas that Susan and I have worked in the past: child abuse and neglect, intimate partner violence, and children's experience of IPV. And I'll speak in a moment to why these are particularly pernicious and important. I also want to note that collective traumas are incredibly important at the group level. So these can be historical and ongoing. And I've put some examples here in the context of Canada: colonialism, residential schools, Indian hospitals. These are collective traumas experienced by Indigenous peoples in Canada that are the effects of which are ongoing and really need to be understood as a trauma that impacts entire collectives of people. We might also argue that the COVID experience has been a collective trauma from which we have yet to emerge, and we don't yet know what the ultimate impacts will be. Oh, I think we skipped ahead. No, I did want to make the point here about how trauma can look in people and how it affects their health. So there is, and we've actually developed a curriculum on this. It's not ready yet, but I will show you the link at which you will be able to find it. We should be posting it in the next couple of weeks, because this is an important reframe as we understand how trauma can present in a practice context. Chronic pain, as we know, is an effect of being exposed to trauma. So there's research evidence that shows the health impacts of trauma, physical health impacts, emotional health impacts, and so on. And chronic pain is documented and demonstrated to be one of these impacts. Chronic pain is also associated with substance use. So again, if you can imagine, when you are experiencing physical, emotional, psychological pain, you want to manage that pain. And sometimes the way to manage that pain is through using substances. And those could be prescription substances, they could be alcohol, legalized substances, or they could be illegal substances. The point here is that chronic pain as a response to trauma and then substance use plays out differently among different people and different groups and different substances. Some substances are stigmatized, some are not. Some people and groups are stigmatized, some are not. So if you start to understand the complexity of people's trauma experiences and the protective factors that may or may not surround them, and then their various use of substances and their social locations, you start to understand why something like the case of Mr. Brian Sinclair in the Winnipeg Emergency Department happened a number of years ago, whereas an Indigenous man, he was assumed to have been using alcohol. In fact, he was not. And he was not properly triaged and died in the emergency department without receiving any care. So this is an important reframe, and this is why we think it's very important to take that structural and trauma and violence informed approach to understanding the impacts of trauma. Because indeed, traumatic stress reorganizes the brain. And this is very important, I found, especially among people who really need to understand a physiological basis for what they're seeing in their patients or clients. I usually say here that fight or fight, freeze, flee response is really triggered by the stress, the fear, that sort of threat to your survival, and you feel that surge of adrenaline, that surge of cortisol. So you are in a space where your brain, the sort of intelligent part of your brain, actually shuts down. And you are prioritizing your physical safety, and that might be by fighting back, or it might be by leaving the situation. When that happens once, your brain, those hormones go away, your brain re-regulates, and you come back into stasis. If you are experiencing chronic complex trauma, where every day you are afraid, for example, if you're living in a violent home, every day the threat, the fear, the coercive control is part of your life, you cannot turn off that response. So you're almost in a bath of these stress hormones. And that does impact the way that your brain works, the way that your body works, and your ability to behave in ways that other people might think would be appropriate for those interactions. So that's an important piece. And again, there are techniques, and Susan will talk about these in a subsequent webinar, that can help reground people, mindfulness, breathing, those sorts of things. But it is a physiological response, and we have to, I think, acknowledge that. And when these things happen, especially early in life, and when they happen repeatedly in these sort of chronic complex situations, they can actually change the way your genes are able to express themselves. And there are studies that show this. I've got one citation there. We've actually done a lovely video by Dr. Andrea Gonzalez at McMaster, looking at adverse childhood experiences, or ACEs, and the impact on brain, behavior, and body. So we need to understand what's going on within people's bodies and what that might look like in an interaction. And then, as I mentioned before, the protective factors or not that might be around them, and how much they've been exposed to trauma over the course of their lifespan will also influence their reaction to later traumas. So if this has happened a lot in early childhood, as an adult, you will be more likely to have a dysregulated response. And again, we've mentioned the severity and chronicity of the trauma and violence that's been experienced. So there's a lot going on here within the individual, but also within the individual's immediate social circle, the community, and the society. And if we link it to things like social determinants of health and the lack of access to broader supports, we start to see that it is really an ecological approach, and there's quite a bit of complexity going on here. Also want to mention the importance of vicarious trauma. You know, we talked off the top about emotional labor and moral distress. Vicarious trauma is, again, an anticipated response to hearing about the violence and trauma that your clients or those around you have experienced. It is absolutely normal to be horrified by the horrific things that happen to people that you care about or people that you're trying to serve. And if you hear enough of this, it starts to become a form of traumatic stress for you as well. And again, each person's response to this will be different. Some people will have more protective factors, more ability to be resilient from these sorts of exposures, and others will not. And you know, one of the points of TVIC is to not judge, to be empathetic and compassionate around those things. And the symptoms of vicarious trauma include the same sorts of symptoms we've talked about for primary traumatic stress. So fight, flight, freeze, fawn. It could look like irritability or disassociation in your colleagues, like I have had enough, I am burnt out. When you start hearing things like that as a leader in your organization, you know, it's time to start thinking about the well-being of your staff. And staff well-being is a very important component of TVIC, because when we talk about safety and prioritizing emotional, cultural, and physical safety, it's for the providers as well, because if we don't care for the carers, then there will be no care provided. And again, I think that's what we're seeing a little bit as a result of the COVID crisis that we've all gone through. So when we talk about vicarious trauma, we look at leaders. So if Sue and I are in a workshop right now, we're looking at organizational leaders saying, this is not just about, you know, more breaks or having a yoga room that people might be able to use if they ever have time to use it. This is about a structural organizational response to the fact that your staff might be suffering. And that means educating your staff. But as we argue throughout our work, education is never enough. You then need to implement some change. Some of those changes might be things like formal and informal debriefing, especially following difficult interactions that your staff have had. And certainly things like reflective supervision in a non-judgmental safe space where a staff member can actually, you know, receive supervision that talks about the emotions that have been brought up, that the struggles that people might be having in terms of the vicarious trauma experiences. And importantly, you know, as available, employee assistance programs or other ways that employees can seek help outside of the workplace and make sure that their well-being is looked after. Organizations can certainly put in quiet rooms and flexible breaks and things like that. Those self-care, you know, options are important, and people do need to look after themselves. But they can't only rely on self-care, I guess is the point here. And organizations can support self-care, but also implement these other strategies. One of the strategies that we talk about in some contexts, it may not be as applicable for home visiting, but in a clinical setting, for example, where there are multiple staff, we call it a tap out protocol. So in some cases, you just are not interacting well with a particular client. You might both be having a bad day, or there's just something, you know, that is not going well between you and a particular client. And a tap out protocol would be sort of a non-judgmental blanket permission to say, I'm not doing well right now. I need a colleague to step in, no questions asked, and do this work for me, and I'll take their work. Because we want the experience to be safe for everyone, and we want to obviously get through a clinical encounter with some, you know, positive outcomes. So we need to be able to shift things on the fly if things aren't going well. So that's an example of a particular strategy that we found helpful in some of our work. So just to recap, you know, I've got on the left here trauma-specific care. That's really not what we're talking about when we talk about informed approaches. That's specialized care. You need people with specialized expertise to do that. And that is targeting the trauma directly through things like cognitive behavioral therapy, motivational interviewing, EMDR, and those sorts of things. Trauma-informed care, as I've mentioned, is a universal approach. It brings that understanding of the impacts of trauma and creates environments that promote that safety. So the goal here is not to re-traumatize people during the care process. You might hear the term trigger or re-trigger. As a violence researcher, I don't like the word trigger, but I think that resonates with people. So you don't want to reactivate. You want to keep people in a good, calm place to have a safe interaction and make sure that your clinical goals are met. One of the issues and one of the reasons that we try to evolve the concept beyond TIP or TIC to trauma and violence informed care is that sometimes this sort of freezes people in the notion that there's something wrong with a person and that what's wrong is in their minds. So it really individualizes the issue of trauma and trauma reactions to the minds of individuals. And that sort of what's wrong mindset can be problematic in terms of understanding the broader context of people's lives and then what might help them. And at this point, I also want to pause and say the biological, the physiological model that I mentioned before is extremely important and it's persuasive. But what we find is sometimes when we describe that, people feel, well, what can I do as a nurse home visitor, as a clinical provider? If that person is having physiological changes, even potentially genetic changes due to the trauma they've experienced or are still experiencing, what can I as an individual provider do? And what we say is there's a lot you can do. Certainly there's this piece. You want to make sure that you are behaving in ways that do not reactivate people's trauma. You want your organization to be set up and your services set up in ways that don't do that. But there's actually more you can do. And that's where we'll start to bring in the V. So please don't feel that you're stuck because this is a physiological response. Okay, so now the V. As I've sort of hinted throughout, we do bring in the V for two reasons. The first is really to focus on the impacts of interpersonal forms of violence. And again, reflecting from before, these include things like experiences of abuse and maltreatment in childhood, intimate partner violence, other forms of interpersonal violence. And the importance of this is, especially in relationships that are supposed to be trusting, like family relationships, it is an abuse of power and a violation of trust. And it actually disrupts your ability to form those meaningful, important attachments. And again, the earlier it happens in your lifespan, especially in childhood, the more pervasive and ongoing these developmental impacts can be, because you will have some people that, having experienced these traumas, find it very difficult to form those attachments. And in fact, what we see is that people who experience maltreatment in childhood are more likely to grow up to be adults that both are victims of violence or survivors of violence, as well as perpetrators of violence in their families. And, I say here, some of that is that you live what you learn. If that's what you learn growing up, then that's what you think life will be like. But also it gets at this issue of being able to form meaningful attachments and trusting relationships. And when those sorts of things happen, you start to see intergenerational cycles. And then as interventionists and clinicians and researchers, we want to find ways to disrupt those cycles of violence and help people redevelop those trusting relationships. And, thinking back to that the level of threat, if you're living, in situations where your physical well-being and even a threat of death is a daily part of your life, those fears, those threats, that the control is a daily part of your life, your safety is paramount. So you do get into that dysregulated state where it's very difficult to re-regulate and reground yourself. And of course, as a gender-based violence researcher, I would argue that these experiences are highly gendered, and the social norms. So now we're at the very outer part of the ecology. The social norms that we live within, that we have internalized, that we express in various ways about gender in particular, have a very strong impact about how violence is expressed, experienced, and understood. And there are different rates and dynamics in men and women and across gender identities. We know, for example, that men are both the primary perpetrators and victims of violence. However, in intimate relationships and in familial relationships, men perpetrate violence primarily against women in the context of domestic violence, for example. So the gender norms actually enable this and often exonerate perpetration and blame victims, to just put it that way. But also the responses will differ according to gender. And here's where I become also very concerned about men. So if men are also the primary recipients of violence more generally in society, but male norms, gender norms about how men should behave mean that you don't ask for help, that it is weak to seek help or seek service, then we see things like deaths of despair being more prevalent among men, and that data is certainly and has become worse during the COVID pandemic. So overdose deaths due to toxic drugs and other sorts of drugs, and suicide deaths are more prevalent in men. So we are structured in a gendered way that makes it difficult for men to seek help and difficult for them, frankly, to not use violence. So we've got problems across the board here, and we need to understand these at a structural and systemic way. Then we add in other factors, other what we call social identities or social locations. So if you're in a racialized group, and in Canada, again, particularly an Indigenous person, if you're low income, if you have a disability, you're more likely to experience these forms of violence. And this often is because of the structures in our society that fail to protect certain groups. So you start to see the intersections of this. If you're a woman who is racialized and living in poverty, the chance that you're going to be experiencing traumatic violence is greater. And we need to sort of address this from a structural level. And I also want to mention here, the issue of implicit bias. This is a way that we've been evolving the TVIC model to sort of understand what we as providers and individuals bring to an interaction, because we often say, at the very heart of things, and this relates to the notion of relational practice, the individual is the intervention. And the way that we start from the first moment we say hello is part of an intervention. And we all bring stuff to our interactions with people. We all have biases and stereotypes and things that we use. Our brains are actually made to do that, to help us sort the world and be prepared for different situations. The problem is that many of these attitudes or stereotypes are problematic in terms of how we understand different groups of people, and can be expressed in ways that are harmful to those that we're trying to serve. So this is some research from my good friend and colleague TVIC, who has done work on implicit bias and how it affects people with mental illness, for example. And often it's not necessarily that people are trying to, be biased against somebody with a mental illness or somebody who's using substances. It's that they don't know what to do. So we know that people are going to emergency departments, not because they want to be there, but because we don't have sufficient primary health care. So they end up at the emergency department because they have nowhere else to go. We don't have sufficient mental health supports in the community, et cetera, et cetera. So an emergency department is not set up to actually, really thoughtfully and take the time to treat these folks. So an emergency department staff member might say, I can't do anything here. But instead of saying to the person and looking them in the eye and saying, I'm sorry, you're going to have to wait quite a long time, because in this place, we start with people who are having acute heart issues and that sort of thing. And I understand your pain. Can I make you comfortable? Instead, we might just avoid that person, not look them in the eye, and basically just ignore them. And if that happens, the service user, especially if they've had many bad experiences in healthcare, will perceive this and experience it as stigma and discrimination. So regardless of what the intention of the provider is, the way that you interact with somebody will be read through their own lenses and their own experiences and prior experiences. And we know that these groups, I talked about intersections of structural and interpersonal violence. Some groups have had very terrible experiences in healthcare. So what we as an individual can do in that first moment is not have that person feel that way. And that is an important thing to do. So TVIC brings together these understandings. It is about critically understanding interpersonal violence and that the complexity and chronicity of some of those experiences. It is having that trauma lens, understanding trauma-informed practice, and then adding these sorts of violence pieces. It is approaching your service and practice from a space of cultural safety and humility, and reconnecting with the values that brought you into the work, and bringing in that understanding of structural violence. So trauma and violence informed care extends TIC to bring attention to those broader social conditions impacting people's well-being. And the ongoing violence, including systemic, historical, and collective violence that I've mentioned, that people not only have experienced, but may still be experiencing. And this can include things like ongoing poverty. And we are seeing it right now. And I will say it is absolutely devastating to think about families falling into poverty or further poverty because of cost of living and inflationary pressures that are happening right now. And the pressure on food banks and other social systems is something for us to be very concerned about, and will change the nature of the stress levels in the families that we serve, and certainly should be something that I would advocate you be aware of. But it also brings attention to those potentially discriminatory or harmful practices in the way that our organizations are set up. So we need to really think about, how are people experiencing our service, excuse me, our space, our organizations, and how do we enhance safety for everybody in those spaces, including care providers and teams. And then again, that reframe, and I did take a minute or two to talk about chronic pain and substance use and their link to trauma and violence, is recognizing some of these things as anticipated or anticipatable reactions to highly threatening events and their ongoing impacts. And that shift can get you from judgment to compassion and empathy. And again, always a good question is, what would I do if I were in that situation, and how would I like to be treated? Excuse me. So that important shift that I mentioned before, from what's wrong in the person's head to what's happened, and it might still be happening in their life. Excuse me. What are the conditions of their lives, and how is that influencing what I'm not only seeing in an interaction, but maybe what I'm able to do when I'm planning a care plan, especially in the context of an ongoing relationship of care in a home visiting program. And again, because I'm a violence researcher, acknowledging that these forms of violence are particularly complex and harmful, and finding ways to make sure that we are attentive to violence that might be ongoing in the home, and having the skills to both recognize and respond safely to those forms of violence in the home. So as a summary, we do want to prevent harm and create safe environments. And that's sort of the core of a trauma-informed approach. And the V then brings in that attention to structural and systemic violence, and how we as providers can situate ourselves to be understanding and compassionate around that. I mentioned a universal approach, and this is very important. And again, I think some of the early work that I and my colleagues did around what's the best way from a woman's perspective to identify her experiences of violence, either in the past or ongoing. And we found through lots of research, and even now the World Health Organization guidelines do not advocate universal screening for intimate partner violence. And there are many reasons for that. I won't go on a side rant, but I'm happy to anytime outside of this webinar. But the idea is that you do not need to have a disclosure to provide care in these ways. You don't need to dig around to know what's happened to somebody and have them retell the details of that. If you are aware of the impacts of interpersonal and structural violence, what trauma can look like, you can attenuate and shift and tailor your care towards the fact that people have had these experiences. And Sue will share with you in a subsequent webinar some particular strategies through the assessment process to understand what those traumas might have been, in the sense that they can influence the care plan that you're going to be tailoring with that family. So it is not about digging for disclosures, and I think that's a really important point here. It is about taking a universal approach to ensure safety. And the accountability happens especially at the organizational level, as well as the provider level, because I'm always concerned, as I say this to you, and as a provider, if I'm giving you new ideas to change your practice, and then you do that, but it's not supported by your organization, that can actually increase your moral distress, because now you sort of know what you can and could be doing to make things better, but the structure is in place, the protocols, the policies, the assessment forms, the documentation requirements, whatever it is actually a barrier to you being able to do the work in the ways that will be more supportive and safe for you and your clients. So we need organizations and leaders to step up. So the principles of TVIC are actually quite simple. And what we found is that they are extremely tailorable to different contexts. So we've actually implemented TVIC in settlement services, in police services, obviously in different healthcare services, in education, primary and secondary school education. This is a model that is highly adaptive and very resonant in different contexts of health and social services and beyond. So the first is to take that trauma lens, to actually understand people's trauma and violence and how it impacts their lives and behavior, with the focus on structural and systemic violence. The second is to create those emotionally, physically, and culturally safe places to actively counter discrimination and stigma. That is a goal of this. The third is to foster opportunities for choice, collaboration, and connection, and then to find and build on people's strengths and help them build capacity to go forward in their own journey towards better health and well-being. Because each of these principles is actually articulated as its own set of strategies for individuals and organizations. And again, I think Sue will go through those in a little bit more detail. But for example, for the first one, understanding trauma and violence and its impacts on people's lives and behavior, we have a tool called the trauma walkthrough. And basically it's going through your space, and it could be thinking about how you enter people's homes to see how people experience the interaction in that space. So if you're bringing people into your own organizational space, how do people initially experience the space? Is it safe? Is it safe for everyone? Maybe some people feel comfortable, maybe others don't. Are there things that you can do in the space to make it more welcoming and safer for people? A good example that came up in a workshop that we did a while back with different professions and organizations in the room was a Children's Aid Society office, actually, who decided to change their lighting because they realized that the industrial lighting that they had in the space was not conducive to keeping, especially Indigenous people who experienced residential schools, in a calm, regulated place. So people would be activated by the industrial lighting, and that would make for difficult interactions once they saw the caseworker. So they changed their lighting. And that's actually one of the more expensive changes that we've heard about. Most of them are actually fairly low cost and easy to do. And Susan and I have talked about what that might look like in the context of home visiting. And she'll give you some tips on that. And at the individual level, it's really, again, looking for those potential red flags or signs and symptoms that somebody is having a traumatic response, and shifting your behavior to accommodate that and get people back to a place of safety. And safety is, what this is all about. Thank you. So again, creating safety might start with the trauma walkthrough, but then also seek input from clients as to how they're experiencing the care in the space and how to create those safe and inclusive strategies. And here's where we might also really pay attention to vicarious trauma and the experiences of staff in terms of their moral distress and the trauma that they're experiencing through interactions with clients, and developing those safety protocols. So those are things that organizations can do. As a provider, you might always be thinking about those power differentials and the differences and boundaries in your relationship. And again, because you're visiting people at home or maybe having interactions in public spaces, this might be a little bit different than it would look in a clinic setting. And these are where conversations with clients can also bring important strategies to the fore. And always being non-judgmental. A lot of what we hear in our research is that clients, especially those from groups facing marginalization, they just don't feel they deserve care. And when you do client satisfaction surveys, you get very high scores, even when you've observed that the care is not good. And because people just feel that they have to be grateful for anything they get. And I would argue that that's not the place we really want to be in, that we want to give good care and people to do that. So be clear in providing information about the programming. So again, people, especially when they've had a loss of control in certain parts of their life through trauma and violence experiences, especially those complex and chronic ones, knowing what to expect in a service can be very calming because there are no surprises. So we want to give anticipatory guidance, to clients about what might be coming next, and always think about safety in the home, in relationships, and view what you're seeing through those trauma lenses. Again, the ability to foster choice, collaboration, and connection at an organizational level. Time flexibility is a huge thing here. So from an equity perspective, and TVIC is part of what we call through our research program, equity-oriented care. Some people need a bit more time and they need more resources. It's not about everybody getting the same. It's about people getting what they need to try to get to better equivalent outcomes later on. And time is a huge thing. So as an organization, the extent to which you can provide, give the clinician, the healthcare provider, the social service provider, the ability to judge how much time to spend with somebody to get them where they need to be, that is a huge shift. And when we think about, for example, in primary healthcare models, fee-for-service, that does not align very well. So in another rant that I often have, fee-for-service is framed as a form of structural violence because it impedes our ability to provide equity-oriented trauma and violence-informed care. And involving staff and clients in identifying, how best to see what's working in the program for them from their perspective, as well as, based around better client satisfaction surveys and things like that. Is it something an organization can do to foster choice, collaboration, and connection? From a provider level, the really key thing here is if you're providing care options and referrals and things like that, they have to be realistic. So if you've identified a family is living in poverty, but there's trauma in the home, expensive trauma-focused cognitive behavioral therapy is probably not a realistic option, especially if there's a 2-year waiting list and it's at the other end of town and will take 3 buses to get there and there are 3 small children in the home. So what are the realistic, feasible options, and how do you discuss that with somebody and listen to them to make sure that a care plan is actually achievable for them? And the final principle is being strengths-based. And again, it's certainly in the work that we've done with women who've experienced violence. Women have lots of strategies to keep themselves safe, and they've done lots of things over time to keep themselves and their kids from harm. Find out what those are and build on them. Identify those strengths, celebrate those strengths, give people that sense of empowerment through the actions that they've taken, and then iteratively build on those strengths and teach new skills to be able to articulate those strengths further. We also, and I think Sue will go over these, have particular skills to help people calm themselves if they've been activated and so on. And again, the organization, this gets back to how we use time, how we allow providers and staff members to use their judgment, and how we allow program options to be tailored to people's needs. So I want to come back to the scenario just for a sec because I'm running out of time. So this is actually from the online curriculum. I'll show you the URL in a moment that we've created on TVIC for public health home visits and outreach. And the scenario is actually centers around Nala and her family. And these are some of the beautiful illustrations that are in the curriculum. So I'm hoping that at this point, you now might have a different set of perceptions about what has been going on with the family, and that your responses to that might be seen through a trauma lens, and might maybe you would come up with some different strategies to help support that family. So the online learning is at this URL, and I see it's been put into the chat. These are free curricula. Sue and myself and other colleagues basically were overwhelmed with requests for workshops. So we started developing online learning tools that are freely available to people. They're housed at the University of British Columbia in their Canvas learning management software, and it is free to use. You just have to register. So the links that are being provided here for you will take you to the landing page at Equip Healthcare, which is one of our research programs. And then you will register for free for Canvas and be able to sign up for these curricula. So this is the one that ends with the Nulla case. There are other cases and scenarios throughout that will help you learn some of these things. Highly recommend it. Takes about 4 or 5 hours, depending on how quickly or slowly you go through it. You can come back and pick up where you left off. There's a downloadable notebook for your reflections and with links to resources and so on. And the first curriculum we created is a little bit more fulsome. It cross-cuts different practice areas and dives a little bit deeper into the TVIC strategies and approaches, looking at it from organizational through team, through individual practice, and then sort of the, what you bring to the work, the implicit bias pieces. So that's the TVIC Foundations curriculum, same initial landing page at the Equip Healthcare website. Highly recommend this. As I said, a little bit longer, but wonderful cases and illustrations. And that brings me to the end of my presentation. I think obviously here's some links and they've been put in the chat for you. My email address is there. Please feel free to contact me. And I think at this point, I turn it back to Sue for Q&A.
Great. Oh, thank you, Nadine. We've asked you the impossible today, to take a 1 to 2 day workshop and compress the key principles into less than an hour. But it's really foundational to help reinforce for clinicians how to think about taking these ideas of being trauma informed, being trauma aware, and really how to prioritize creating emotionally and physically safe environments in practice. So thank you for giving us that foundation. Now we've just got a few minutes and we've got some really great questions here. So the first question is you've identified that when individuals experience trauma, that results in a reorganization of the brain chemistry, which influences how people think, feel, and behave. When we look at it from a strengths-based perspective, when people have experienced that traumatic stress, is there hope that their engagement in different types of interventions or therapies, can reverse some of that? Like, is there hope, right? If
of course, and there's there's always hope, Sue, and certainly that. I'm no expert in brain chemistry, and nor am I an expert in trauma specific care. However, I do think an important point from a clinical perspective, or somebody interacting with people, they will be at various points along this journey. And certainly we know survivors often get to a point where they have at their point of their healing journey where they want to give back and participate in helping others get through that journey. But that's really sort of quite a bit later in that healing journey. And I would say you're going to encounter people at each step of that journey. Certainly assume that they can get to the end step, that there is the opportunity, especially with your help and in your role and what you can do to provide supports and tailor care to help them along that journey. And it is a journey, and you can't presume that where people are at, but you can listen and understand through a trauma lens where that might be. Absolutely, there's always hope, and that's why I do get concerned if we focus too much on the changes to the brain and the physiology, and then the answer is either more chemicals or mindfulness, which can be incredibly useful, but it almost absolves us of our responsibility to create that safety and keep people moving along the journey. So that's the balance, right, with that approach. So I hope I've answered that question.
Yeah, no, great, thank you. And then building on that, so you've identified that within a clinical care encounter, if individuals feel unsafe or triggered or activated, that is a reality. So I appreciate this question because it's a focus on prevention. What strategies can a clinician implement right up front in their care encounters with everyone so that they can really try to keep an individual in that sort of safe, regulated space rather than being triggered?
Yeah, and I'm probably sliding into some of the strategies that you might be sharing in the next webinar, Sue. But I do think there is a fundamental sort of human respect that you begin an interaction with. And I know in nursing, it's called the NOD protocol. So you start with your name, your role, and what you're going to do today, your duty. So hi, my name is Nadine. I'm from this program, and today we're going to be doing this. And you look somebody in the eye and you speak, to them as a human being and with respect. So that's the start of you as the intervention, you as a trauma and violence informed intervention. Certainly, if people are already activated when you begin, there are ways to slow your own voice to, again, make sure that people are following along with you. If they've disengaged, try to bring them back. model the behavior you'd like. So calm your own breathing, and they might mirror that back. So there are techniques, and Sue will go into these in a bit more detail, and we address them in the online curriculum as well, to get off to a good start, even when somebody might not be coming to you at their best. And I always say this to emerge folks: people aren't at their best when they come into the emergency department. So you need an extra scoop of patience and respect, to accommodate the fact that, people are often nervous just at a baseline. And then if there's trauma activation going on, then you're going to need to do a bit more work to help them be able to get back in a place where they can interact with you.
How, as a clinician with our own histories of trauma and activation, when someone is angry with us and they're really disrespectful to us, what is the best approach from that clinician perspective when we're faced with those emotions to us?
Yeah, and that's, more and more an issue. Unfortunately, I think we've certainly seen that over the last few years. I don't know if I have a perfect answer to that, Sue, and I'm happy to hear your thoughts as well. But I do think it is knowing what those centering techniques are and applying them first to yourself. So whether that's a few deep, breaths in through your nose, out through your mouth, sort of calm and center yourself. And I mentioned, if you can get to that point, the idea of a tap out protocol. So if you're in a space where there are others who can take over an interaction without judgment, but that's not often the case if you're doing a home visit, for example, it might just be saying, this is not a good time for either of us to be having this conversation. And I really don't want things to go off the rails in terms of our ongoing relationship. So I suggest that we, maybe reschedule at a time when we're both feeling a little bit more grounded and ready to have this conversation and do something useful together. So that might be sort of the ultimate bailout strategy if things are really going off the rails. But I also think there's that empathy piece, and empathy is different than sympathy, right? Empathy is, I can put myself in your shoes and try to understand what you're going through right now and how I would want to be treated. So if we can start with that place of empathy and compassion as a process. So I'm, not as a thing that you give somebody. That's why I don't like the term compassion fatigue, quite frankly, because it sounds like, well, I have my quota of compassion and I ran out with Mrs. So-and-so, so you don't get any. That is not a TVIC way of thinking. Compassion is a process, and we learn and we get better at it. And we behave in that way, in a dialectical way with people.
Great, thank you. Another one is, okay. One of our attendees has identified that they recently read somewhere that the practice of workplace debriefing after a traumatic incident can often reinforce a chronic trauma response or PTSD. Are you aware of this evidence, or could you share your perspective around the impact?
Yeah, I'm not aware of the evidence, so thank you for that. I'll certainly look that up. I think, as with everything else, it's how you do it. So, we have developed through the Equip Healthcare site, and you have the link to that, organizational implementation of these strategies. And one of the foundational principles is you need to create a safe space for these discussions to happen. And that means acknowledging, as mentioned before, that we as individual professionals, as just people in the world, have also had experiences of trauma, and we might be activated in ways that we can't even predict. It might just flare up in a moment and we don't know. So it's up to the people, in this case, the organization that's setting up this structure of debriefing to ensure that it is done safely. And that might require some training in things like grounding techniques, but also some facilitation. So if you're going to enter into it, you've got to take that TVIC lens to it, and make sure that you're not reinforcing bad behaviors, but actually, achieving the goal you want to achieve. So you can't just sort of throw things in and hope they work. I think each strategy needs to be analyzed through that TVIC lens, with the priority being safety for everyone involved.
Okay, excellent, thank you. Okay, here's another question.
You might have to answer this one, Sue.
I don't, because I think this is a fundamental question. So I think whoever has asked this, I like the idea about flexible staffing to prevent vicarious trauma. However, it only seems possible when there is adequate staff. How can we remain flexible in these short-staffed contexts that we are currently experiencing?
I wish I had an answer to that question. Right now, I'm getting requests to do TVIC webinars and trainings like you wouldn't believe, because people are just in the space of moral distress and almost panic around this. I have a colleague who works in the emergency department here in one of the EDs here in London, and normal staff complement is 22. They're down to 11. What do you do in that? Yes. So all of this seems like a nice add-on when you're in the context of sort of all hands on deck, the house is on fire. But I would say that it's actually more necessary to start with these principles. And what you do is the best that you can through that TVIC lens. It might not be a tap out protocol if there are not enough people on duty to do it, but there might be something else, and you will hear the good ideas from the whole team. So when we do organizational implementation, we have the reception staff, we have the custodial staff, security staff, whoever is in that space is bringing solutions forward, because they each have a different perspective on the care experience, and they know what can go wrong for people. And if you're in the back all the time conducting clinical interactions, you might not see what's happening in the front. So you need everybody strategizing. And again, finding the time, that's leadership, right? That's leadership, is finding the time in a crisis.
No, excellent. And one last question. Do you have any recommendations around approaches to doing with respect to, you mentioned child protection. Is there any way to reduce the traumatization when a nurse or clinician has to make a report to child protection?
I'm not sure we have time to answer
that
one. So that's a big question.
I know.
And it's very, very complex. And, so I actually prefer not to go there given the time.
Fair enough. And there's a whole other, there's other great questions that have been asked, and I've quickly copied them down because a lot of them are around how do we do complex assessments, such as asking about intimate partner violence, how to do the in-depth assessment, how to do something like the danger assessment, which is a risk assessment for femicide or homicide. And those are going to be the focus of our next webinar. So I'm going to hold, though I've copied those questions. I also noticed that there's some questions around, should we abandon universal screening for intimate partner violence and move, and Nadine's alluded to that. And I'm thinking that maybe for a future webinar, we may pick a topic around asking about intimate partner violence. I know in the next month that I'm coming to Toronto Health Unit, Southwestern Health Unit, and up to a few others in the new year potentially. And that will be a big focus, is thinking about trauma and violence approaches rather than universal screening, to asking or exploring individuals' experiences of violence. So, but I think there will be some value to doing that as a webinar. So I'm going to just wrap up now. Thank you, Nadine. These were, people have asked the questions that are difficult and that health units are grappling with. So thank you, Nadine, so much for sharing, for introducing the 4 principles, for highlighting the reality that we live in right now around the impact, particularly of structural violence. And this will be a great foundation as we move forward for the next year to focus on different topics related to, implementing these principles into nursing and clinician practice. And so our next webinar will just be in a few weeks. I know there's a typo there. I'm so sorry. Of course, I only notice it once I see it in a big screen yesterday. Anyways, on November 9th, I will be doing a webinar. The registration link will come out this week. Health units have been sent the hold the date. And this next webinar is really going to talk about how do we use these principles to talk about some of the difficult topics that we have in our clinical practice. And then how do we sensitively and create safety when there are required assessments that we're going to have to do. And I remember in, I think, 1998, the first time I did an in-depth assessment when I was a public health nurse in the original HBHC program, and thinking, these are hard questions to ask. And sometimes I don't want to ask the questions right on that first visit. So, this is going to be the focus of this next webinar, is how do we do these difficult assessments in a way that minimizes, the activation of a trauma response amongst our clients, but also facilitates clients feelings of safety to share this information so that we can develop a plan of care to support them in meeting their goals for themselves and their family. So stay tuned. The registration link is going to come out. Thank you, Nadine. Sarah, thank you for co-moderating. And again, thank you to Public Health Ontario for hosting. This session is recorded, and the link and the slides will be available in about 2 weeks on the Public Health Ontario website, as well as on the PHN Prep website. So thank you, everyone, and have a great day.